And thank you all for joining us. Today we have our final speaker in our series as we explore vaccine outreach and what that means here in Montana, hearing from some of our very own Montana experts talking about their research and their efforts related to vaccination. Today we have with us Dr. Sophia Newcomer, and she is a faculty member at our comrade in arms at the University of Montana, and she's an assistant professor in the School of Public Health and Community Health Sciences. I'll let her share a little bit more about her background and expertise as she gets started. If you do have any questions as you are joining in, please do feel free to put those in the chat, and as we have time, we will respond to those as well at the end of her presentation. So, Dr. Newcomer, I will let you go ahead and share your screen and begin sharing with us what you are exploring.
Sure, thank you. And thanks for inviting me. And it looks like right now we have a small group, which is fine. I'll introduce myself a little bit and share my screen. And if we still have a small group and people feel comfortable, I'd love for you to share, maybe come over the line in a minute or in the chat, just maybe who you are and what you're interested in, because it could help me just in terms of tailoring what I talk about today. But I'm Sophia Newcomer. I'm a faculty member in public health. I'm an epidemiologist by training. I joined the faculty here at University of Montana in 2018. And prior to that, I was an epidemiologist in Denver, Colorado with Kaiser Permanente, Colorado's Institute for Health Research. And there I worked for 10 years in collaboration with the CDC on vaccine safety research. And so I came here to Montana with this keen interest in vaccines as an important public health strategy, and honestly a crucial public health strategy in terms of infectious disease prevention and control. And here in Montana, what I've been focused on is immunization services delivery research. So that's research that's focused on understanding barriers to vaccination and looking at strategies for increasing vaccination rates. Largely focused on routine childhood and adolescent vaccines. And so that's what I'm going to be talking about today. So while I share my screen, if anybody wants to come through the line and just share who they are or just put a little note in, I'd love to kind of just get an idea of who I'm talking to. But if you don't feel comfortable, that's okay too.
And I don't think our participants can actually come off of mute, but you can type into the chat, and I can share that as well.
Oh, okay, thank you.
Yeah.
All right, let's make sure we are all set up. So, do you see my presentation? Okay, great. All right, so let's dive in. Great. So what I'm hoping to talk about today is, first, I just want to spend a little bit of time giving a big picture on what we know about vaccine coverage in the rural US, including in states like Montana, and then talk a little bit about vaccine hesitancy, which right now is getting a lot of attention as a barrier to vaccination. Then I'm going to move forward and talk more about vaccine hesitancy and other barriers to vaccination that we experience here in Montana. And then I want to wrap up by talking about some evidence-based strategies for increasing vaccination rates. So just big picture, we know that in the US, vaccination coverage persistently lags in rural areas as compared to more urban areas of the country. And here I just have the most recent data from CDC. Over here on the left, this is completion of the combined 7 vaccine series for kids at their 2nd birthday. So any of you who are parents, including myself, might know that when kids are little, they are recommended to get several different vaccine series, actually up to 10 different vaccine series, and CDC monitors completion of 7. So if we see here, what we just see is this is overall US, rural vaccination rates are lagging behind, and then here in Montana, our rates are even a bit lower. But you know, it kind of varies based on what vaccine you're looking at. Influenza in childhood is actually higher in Montana, so we're doing a better job than the country in terms of making sure our kids are protected against flu. And then this is HPV, human papillomavirus series completion, which is recommended that kids start this multi-dose series at age 11 or 12. And we're also behind the national average. And it's just important to note here that, we definitely do see some rural-urban disparities with regard to vaccine coverage. And in the US, we are lagging behind in terms of meeting our established public health goals. So for example, human papillomavirus series completion, HPV, we would like that to be closer to 80%. So that we can really work toward a shared vision of reducing HPV-caused cancers and other diseases in the US. And then, of course, I'm talking about routine childhood and adolescent vaccines, but we've also seen the case with COVID-19 vaccination that rates are lower in rural areas of the country as compared to the more urban areas. And CDC has been doing some surveys to monitor vaccine confidence with regard to COVID-19 vaccination. And if we see here, this data is just about 6 weeks old. But what we see here is the percentage of rural participants who said they're vaccinated is lower, and also the percentage saying that they probably or definitely will not get vaccinated against COVID-19. Vaccination is higher than what we see in urban areas. And with regard to COVID-19 vaccination, much of this choice is definitely due to vaccine hesitancy. So World Health Organization, prior to the pandemic, I believe in 2019, they recognized vaccine hesitancy as a top global public health threat. And their definition of vaccine hesitancy is it refers to the delay in acceptance or refusal of vaccines despite the availability of vaccines. It's complex and it's context specific, and it varies. And so what you won't hear me say is anti-vax or pro-vax. It's much more complex than either being for or against vaccines. And vaccine hesitancy is influenced by multiple factors, including complacency, convenience, and confidence. And so to kind of give a picture of vaccine hesitancy as a spectrum, this is a spectrum that was proposed prior to the pandemic, and particularly talking about vaccine hesitancy among parents. So prior to COVID-19, the majority of research on vaccine confidence and vaccine hesitancy has been focused on parents and the decisions that they have to make about the vaccines that are recommended for young children and for adolescents. And vaccine hesitancy is certainly a spectrum, right? We have the majority of parents accept vaccines and accept their clinician's recommendation to vaccinate their child. But parents can also accept vaccines and have concerns. And in fact, a high percentage of parents, over 75% of parents from surveys have it's been reported, over 75% of parents have questions or concerns about vaccines. Parents can choose to delay some vaccines, delay all vaccines, delay some vaccines, refuse some vaccines, refuse all vaccines. So it's certainly a spectrum of both behaviors and beliefs regarding vaccination. And just to summarize, we have, based on previous research, there's some key findings on vaccine hesitancy that I think are important, especially when we're thinking about clinical and public health practice. So like I alluded to, most parents have questions about vaccines, and most parents choose to vaccinate their children. So having questions does not mean lack of intent to vaccinate. It's also been shown that parents revisit their vaccine decisions frequently. So parents who have reported that they have chosen to delay or refuse some vaccines that are recommended for their kids, a high percentage of them also report that they revisit this decision and are open to changing it in the future. So people can and do change their minds. And this, from a public health standpoint, means that there are multiple touch points for intervention. And multiple surveys among people who are and are not vaccine hesitant have shown that doctors and nurses are the most trusted source of vaccine information. And how medical professionals recommend and talk about vaccines is highly influential in vaccine decision making. So we've talked a lot about parental hesitancy, and there's a lot of drivers of vaccine hesitancy. Vaccines are often called victims of their own success. They've been so successful at greatly reducing or even eliminating disease risk for some diseases that used to cause really profound disability and death rates in children. They've been so good at suppressing that disease transmission that the benefits of vaccination nowadays can be hard for some parents to see. And instead, there's more of a kind of tilt toward thinking about risk of vaccination. And so a lot of parents who are hesitant about vaccines cite concerns about vaccine safety, concerns about both long-term and short-term side effects from vaccination. There's declining trust in the government, and the government, especially the CDC, is very involved with how immunization services are delivered in the US. And then, of course, we have an epidemic of misinformation and disinformation on social media, which overstates any safety concerns and does not talk about the benefits of vaccination as much. But hesitancy is not the only reason that we are not meeting our public health goals with regard to child and adolescent vaccines. There are also structural barriers, just barriers to healthcare access that are also factors when we think about accessing immunizations and immunization services. So especially when we're talking about medically underserved areas, like we do have areas in Montana that are medically underserved. There's a lack of immunization providers that might be available. You can talk about long distances that people have to travel to get to immunization providers. Particularly when we talk about childhood vaccines. Again, if any of you have had young kids, especially recently, you might remember that there's a lot of visits that kids need, right? Kids have a well child visit schedule with many well child visits recommended between ages 0 and 2 years. And the administration of vaccines is recommended to be aligned with that schedule. But if you're not sure when you need to be bringing your kid in or what vaccines they're due for, that can be a hard process to navigate. And along the same lines, many of our vaccine series are multiple dose series. I think many of us are aware of that right now with regard to COVID-19 vaccination. It's not just a one dose event, it's a multiple dose event. Most vaccines are like that. And so that can be complicated to navigate from a health access perspective in terms of making sure your kid gets in for all the vaccines and all the doses that they need for full disease protection. Okay, I lost my mouse. Okay, there it is. All right, so moving on, I'm going to talk for a little bit about some of the research that I've been involved with in terms of identifying in Montana, why are we falling behind in terms of routine childhood and adolescent vaccination rates? And then we'll talk about what might be some strategies we can use to address this problem. And most of my research here is funded by the National Institutes of Health. And a lot of the research I do is in collaboration with the Montana Department of Public Health and Human Services, so Montana DPHHS. And so the first project I want to talk about is a project that has been funded by the NIH, the National Institutes of Health, for the past 2 years. It got funded right before the pandemic started, but the goals are to quantify how much of this under-vaccination problem we have in the first 2 years of life, so what I call early childhood, the littlest kids in Montana, how much of our under-vaccination problem in Montana is due to parental hesitancy versus due to these other structural barriers. And then we also sought to determine whether there are spatial clusters of specific patterns of under-vaccination in the state. The reason we were interested in this second part especially is because, and I'll talk about this at the end, but strategies for addressing parental hesitancy are very different than strategies for increasing healthcare access and facilitating access to immunization services. So if we were to find that in a huge state like Montana, that these problems are really occurring in different areas, that could really be helpful in helping to steer public health resources. So we worked with the state and we did an analysis of MTRACS data. So some of you might be familiar with MTRACS. It is our state centralized immunization information system, our state IIS, and really these state IISs and all states have an IIS. These state IISs have two purposes. The first purpose is at the clinical point of care. Clinicians need this information. They need to know what vaccines people have gotten so they know, okay, you've already gotten this, you're recommended to get this. So we need it for the point of care. And then these state IIS data are also used for population health. So for reasons like this, so that we can look at data and decide where the gaps are and where we can steer public health resources, which is what we are doing here. So we did an analysis of a limited data set. We worked with the state on this. We identified kids who were born in Montana 2015 to 17 that had at least one record in this database. And they had to have at least one record after their first birthday, because two of the vaccines we were interested in looking at as part of this combined 7 vaccine series are given after the first birthday, MMR and varicella. And we had to exclude a small group of children that had some, data issues, which is pretty common when you're doing a big epi study. And so we ended up analyzing data on about 31,000 kids. And what we did was we looked at their pattern of vaccination. So typically when we talk about vaccine coverage, we just look at your second birthday and we say, okay, let's do a checklist. Did you get this vaccine? Did you get this vaccine? Did you get this vaccine? Well, instead of doing that, what we did was we looked at the pattern of vaccination from 0 to 2. So I've been involved with previous work that has shown that there are certain patterns that are highly indicative of parental hesitancy. So for example, getting some recommended vaccine series, but not starting other series is typically indicative of a parent selecting. It's called selective vaccination, a parent saying, I want some, but not all of the vaccines that are recommended for my kids. Another pattern indicative of parental hesitancy is spreading out vaccines. So one common concern that parents have is that kids get too many vaccines at too young of an age, or too many vaccines are recommended at one visit. So some parents choose to spread out vaccines. This is often called shot limiting or vaccine limiting. So we can look in the data and see when that's happening. However, there are other under-vaccination patterns that are more indicative of structural barriers. So we see in our data kids that are getting all their series, but getting some doses late. And then we also see kids that are starting all their series, but they're not completing all their series for some of those reasons that we talked about earlier. So we did an analysis working with the state of data on Montana children, and this is what we found. We found, I'm going to start over here, that about 38% of kids in Montana are getting all of their recommended vaccine doses on time. So this is what we call the recommended schedule. So this is, they're getting vaccines per the schedule recommended by the Advisory Committee on Immunization Practices, or the ACIP, which is which is the schedule that clinicians follow. But then we found that about 18% of kids look like they are under-vaccinated per a pattern indicative of parental hesitancy. So either shot limiting or that selective vaccination pattern I was talking about. We have a small group of kids, about 2%, who look like they're starting all their vaccine series late. That could either be indicative of parental hesitancy or structural barriers, so we didn't really classify that. But then looking here, we see that we have 20% of kids in Montana, so 1 in 5 kids, have started all their recommended vaccine series. They just haven't completed all their recommended vaccine series by their second birthday. And so that is more indicative of structural barriers to healthcare access. And then we have 22% of kids got all their vaccines, but received some or all doses late. When we talk about vaccine coverage, we are talking about these two parts of the pie. But by looking at it this way, we see that even if you're done by age 2, we have some kids who have received vaccines late, which of course we expect this to happen, right? Life happens, but it's something we want to monitor, because we do know from prior research that even just having periods of under-vaccination leave you more vulnerable to vaccine preventable disease risk. So then we did another analysis where we sought to look at whether there were clusters of spatial clusters throughout Montana where some of these patterns were more prevalent. And the way we did this is we looked at geomasked addresses. So we didn't have people's actual addresses. We did a geomasking procedure to ensure confidentiality of data. And then we did what's called a spatial statistical analysis, where essentially we drew all of these many random circles around Montana and sought to determine whether the prevalence of kids with a certain pattern within the cluster was higher than outside of the cluster. And I'll share these results. Oh, I should note, these results have been published. These results remain unpublished, so should be considered preliminary until they're published. The first thing we looked at was just failing to complete the combined 7 vaccine series by age 24 months. So basically looking at kids who had not gotten all doses from these 7 vaccine series by their 2nd birthday. And what we found some 5 significant clusters throughout Montana, and it was spread out kind of pretty evenly throughout different areas of Montana. But then when we looked at certain patterns, we saw that clusters were evident in different areas of the state. So when we looked for these patterns that were consistent with parental hesitancy, we found significant clusters in Western Montana. This was not a huge surprise, given that we know that Western Montana has lower overall childhood vaccine coverage than other areas of Montana. And when we look at data also on exemptions, in particular religious exemptions that parents can get for children for school entry with slightly older children, we know that those are also more prevalent in Western Montana. So we saw that these clusters consistent with parental hesitancy were more clear in Western Montana. In contrast, under vaccination due to structural barriers, so under vaccination where kids are starting all their series but not finishing all their series, seems to be more prevalent in eastern parts of the state, where there are likely greater barriers to just accessing healthcare services. So like I said, and I'll kind of give a summary at the end, this information has been really helpful, especially working in the state health department in terms of helping to steer initiatives or think about different strategies for increasing early childhood vaccine uptake. I want to talk about one more study I've been working on, also in collaboration with the state health department, on missed opportunities for HPV vaccination. So this is human papillomavirus vaccination recommended for kids starting at age 11 or 12 years. And it's a vaccine that can prevent against several HPV-caused cancers, including cervical cancer in females, but also several types of cancer in males as well. So for this study, we also analyzed a limited data set from MTRACS working with the state. And what we were interested here is looking at adolescents who are coming in for other vaccines, but they are not getting HPV. So that's what we call a missed opportunity, right? You're there, you got your arm out, you're recommended at age 11, 12 years to actually get 3 vaccines, DTaP, meningococcal, and HPV, and then also flu if it's during the flu season. And here in Montana, kids are required to get Tdap prior to entering 7th grade. So even if you just took a step back and looked at our DTaP rate, our Tdap rates versus our HPV rates in Montana, we know that there are missed opportunities occurring. So we wanted to do a deeper dive to figure out, well, where specifically are these missed opportunities occurring? We looked at a couple different things, but what I'm going to talk about today is clinic type. So in our analysis of 47,000, about 48,000 adolescents in Montana, this was over a multi-year period, 56% had a missed opportunity to be vaccinated against HPV. So that means they had presented for another vaccine after their 11th birthday. They are eligible to be vaccinated against HPV, and they did not get the vaccine. And among these adolescents, they had over 71,000 visits, and about 54% of those visits were missed opportunities. I'm just going to highlight one set of results, which were really our most interesting results, where we looked at missed opportunities by type of clinic in Montana. So most kids and adolescents go to private clinics for routine primary care, including immunizations. However, public health departments are a major provider of immunization services, particularly in rural areas, both here in Montana and across the U.S. We also have clinics that are designated as rural health clinics. We have Indian Health Services and tribal clinics, and then we also had a category for FQHC, federally qualified health centers and community health centers, and then also this other category, very small, but other includes like urgent care and kids that may be in the hospital and got vaccines while they were, hospitalized for a broken bone or something. But anyway, what we saw is that when we looked at missed opportunities to vaccinate against HPV, they were highest in public health departments. Actually, I should note they were highest in these other settings, but we weren't particularly concerned there because this is a small hodgepodge. But this is very interesting in terms of kind of just potential for future work. So when we think about a public health department as opposed to a private clinic, when you go to a private clinic, you have a primary care provider, someone your family's had a relationship with, you go for routine care, you're bringing your child in for routine care. In contrast, people go to public health departments, not for routine care, but really like episodic care. And oftentimes, if you're going to the public health department, you're going with like a vaccine in mind. Like, I am bringing my child here to get the flu vaccine, to get Tdap. And so a lot of the prior work on how we promote HPV vaccination in the US has really focused on what works in these private clinics. And I think there's a real opportunity here to figure out what works best in terms of promoting HPV vaccination in public health department settings. And we'll talk about strategies in the next part of this conversation. Of note, I want to point out that the lowest rates of missed opportunities were in our Indian health services and tribal clinics. And that really aligns with what we knew already about higher HPV vaccination rates in American Indian population in Montana. So I think there's also a lot of opportunity to learn from what's working well from immunization services in IHS and tribal settings. It could be that there are kind of just more standardized and routine clinical processes around recommending vaccines, greater trust between communities and providers. But I think that there is a lot that we in Montana can learn from what's working well in IHS and tribal settings. Finally, I want to spend a little bit of time talking about the science behind what works, what we know works for increasing vaccination rates. And given my research, I get asked a lot, what can we do to address vaccine hesitancy? What can we do to change people's minds about vaccines? And I have started to say that I think we should change the question. I think the question, instead of just talking about vaccine hesitancy, should be what works to increase vaccination rates. So I'm going to talk a little bit about these strategies, and then I'll tie it back to say how I think these strategies will actually work to increase vaccine confidence as well. So there are several evidence-based strategies for increasing vaccination rates. Many of these strategies involve our provider level strategies, clinic level strategies, and I also want to underscore the importance of public policy. I'm not going to talk about public policy beyond this slide, but I do want to say that there is a lot of evidence that shows that, for example, requiring vaccines for schools increases vaccination rates, decreases vaccine preventable disease transmission, and also saves the taxpayers money. And the way we know that is that when states have become more lenient in these policies, they've seen outbreaks go up, they've seen vaccine coverage go down, outbreaks go up, and the cost to the taxpayer for managing these outbreaks can be quite astronomical. So policy does work and is an important part of our public health toolbox. Let me talk a little bit about provider level and clinic level strategies. And in particular, I want to talk about the research that's been done on how doctors and nurses can talk about vaccines, and then also some clinic level strategies. So there's been quite a bit of science and research on how to talk and how to recommend vaccines. And this all occurred prior to the pandemic, and it was very much focused on how doctors and nurses talk to parents about childhood and adolescent vaccines. And so there's a lot of research that shows that presumptive vaccine communication is the way to go when you're starting a vaccine conversation. So the way this might look is if a doctor or nurse is in a clinic with a parent and a child, start by assuming that the parent intends to vaccinate. And that might sound like, well, we have some shots to do today. Now that Sam is 2 months old, he needs 4 vaccines today. Allie, who might be a teenager, I'm guessing here, is due for 3 vaccines today, meningococcal, HPV, and Tdap. This presumptive approach is in contrast to more of a participatory approach, which is to say, oh, do you want to consider vaccines today? There's been several studies that have shown that the presumptive approach is more effective in increasing vaccine uptake. This is a couple studies. I'm just going to brush through them. Basically, this has shown that this one middle study that was done in Washington State showed that children whose parents were exposed to more of this participatory format, they had lower vaccination rates than parents whose providers used a more presumptive or announcement type conversation starter to vaccines. But I think what was really compelling was there was a randomized trial done in North Carolina where clinics were randomized and the doctors and nurses there either received training on the presumptive approach of starting vaccine conversations or more of a participatory approach. And the clinics that had the training in the presumptive approach had 5.4% greater increase in HPV vaccination rates. So that's the kind of science and background on starting the vaccine conversation. But then, of course, you can start the conversation that way. And I have this on my last slide, but starting the conversation that way really helps establish vaccination as the norm. And it also helps people when they are, like we said before, many parents have questions and concerns about vaccines, but most parents are going to choose to vaccinate. And kind of just seeing that established as the norm helps that parent who might be concerned feel a bit better about saying, okay, like this is the right thing to do for my child. But there's going to be many cases where you can start the conversation that way and the parent may still not be ready to vaccinate. So in those cases, we're really looking for immunization providers to offer a strong recommendation to vaccinate. So emphasize the importance of the vaccine and the importance of getting it today for disease protection against your child. Address parents' concerns. It's okay to have questions and concerns about vaccines, and we know that many parents do. So address those concerns and personalize it if you can. So for example, I'm not a doctor or nurse. I don't give vaccines. I get asked a lot of questions when people know what I do for a living. And I say, hey, I've studied this for 15 years. I know a lot about this research. And I made sure my kids were vaccinated on time for all the vaccines that they're recommended for, because I know that that's really important for them and for their health and also for the health of our public. So kind of just sharing, I feel comfortable sharing that kind of my personal motivations with others. There's a lot of research right now that's really interested in motivational interviewing as a strategy for helping people work through concerns about vaccines. So, vaccine decision-making can be quite complex, and it's really hard to navigate if you're a parent and you're getting bombarded with all sorts of information. So motivational interviewing is a strategy that can be used to help people walk through the complexity of decisions that are involved. And it invites people to talk aloud about their concerns. And part of this is probing them to share what they think the benefits of vaccination would be. And again, responding to questions and concerns can be very important here. I think what I hope you're hearing is that there's no evidence for just writing people's concerns off. Concerns are important, and they're important. It's important that we hear them. I want to talk finally about reminder recall, which is a clinic level strategy. Essentially, it involves clinics reminding people when vaccines are due or recalling them when they're overdue. There are several decades of studies that show how effective that reminder recall can be. And it can be effective for all types of populations, children, adolescents, elderly adults, and all types of vaccines. And it can be effective using multiple methods. So nurses calling people, sending letters, sending postcards, text messages. And there was a meta-analysis done where they looked at 55 different studies. And this shows, these studies showed that reminder recall can increase vaccination rates anywhere from 5 to 20%. And just, briefly, I talked about this a little bit, but why these strategies are evidence-based strategy for increasing vaccine uptake, but they also help contribute to vaccine confidence. So like I talked about, presumptive communication establishes vaccination as the default action and eases some parents' concerns when they see that their providers are so confident in recommending and talking about vaccines. Reminder recall, it establishes routine on-time vaccination as the norm. I think about right now, I have this vision of if everybody was getting pretty continuous communications from clinics about when they were due for vaccines or when their kids were due for vaccines, I think that would really help the public see, wow, we think vaccines are so important that my clinic is investing time and resources in making sure they remind me. But that brings up the big problem. Doing something like reminder recall takes a lot of time and resources. So that can be a really big barrier, especially in states like Montana, where we already have a health workforce shortage. And also reminder recall provides a nudge or a cue to action. So you might already be thinking, oh, I need to get my flu vaccine. I need to get my flu vaccine. I need to get my flu vaccine. Man, if you start getting text, to help remind you or tell you about a clinic, that's a nice cue to action to go ahead and take that action to get the vaccine. All right, to wrap up, just kind of briefly what I've learned, and of course this work is not just done by me. I've got a wonderful team here of students and research partners, and of course this is all done in partnership with the state health department. What we've learned is vaccine hesitancy is an important contributor to under-vaccination in rural areas, especially in Montana, but other structural barriers are also important challenges. And like I showed, we really see that in this huge state of Montana, the prevalence of these types of barriers can really be different, whether you're talking about Western or Eastern. And so therefore the strategies that we need to be looking at are also quite different. And we can rely on looking back at evidence-based strategies to kind of help us think about initiatives that can help us move forward in increasing vaccine confidence, reducing structural barriers to vaccination, and increasing vaccine coverage. All right, here's a view from the M. I did not take this picture, but I really like it. So I'm going to stop my share, and then I would love to have a conversation or entertain any questions.
And for folks that are joining us live here, feel free to type in questions into the Q&A or into the chat, and I will share those as well. Dr. Newcomer, thank you so much for sharing. That's really, I think you shared some really important information and helps us to better understand what is happening here in Montana related to vaccination and children as well. And I have a couple of questions to get us started in a little of this discussion as well, as we're waiting for a couple of questions to come in. So I'm wondering, what are your thoughts? We've been talking in this series a lot about vaccination specifically related to COVID, and I know that that is kind of newly rolling out for youth across the country as well as here in Montana. And I would imagine having some probably similar challenges to what you're seeing in other vaccinations. What are your thoughts around how that rollout is going, or maybe some suggestions, especially for folks in the community that might be talking to other parents or other friends around vaccination in general, or maybe COVID related?
Yeah, so with regard to COVID-19 vaccination, the recommendations, especially for younger kids, including the age that my two kids fall in, by the way, 5 to 11, is fairly new. But we have a lot of evidence already in the millions of people that have been vaccinated, of course, evidence from the clinical trials regarding the safety and efficacy of these vaccines. I think what really has made COVID-19 vaccination unique is that, unlike all other vaccines, COVID-19 vaccination has not until recently lived in primary care, right? People have been going to big clinics or going to the pharmacy, which is great in terms of, letting there be wide access. But when it comes to parents and the decisions that they make about vaccinating their kids and their adolescents, they are used to talking about vaccines in their primary care office, and I think that is going to continue. So I was really happy. I've been very encouraged in Montana. More and more primary care offices are carrying COVID-19 vaccine and carrying it for kids. And we're certainly steering parents toward having those conversations with their primary care providers. In terms of having those one-on-one conversations, I think it really differs for everybody, kind of depending on who you're talking to. Again, if you feel comfortable, I personally share kind of my personal, this is what I do for research, and this is why I think it's important for my kids. But I'm really glad. I feel like what I hear locally and nationally is this conversation about not shaming. Like we know, like shaming will not be effective, and so just being open to listening to people's concerns, and then encouraging people to talk to their medical provider if they have concerns.
Great. So another question here as well. As you were looking at the different clusters around Montana as well, I was wondering if there were any other additional demographics that you looked at that might be related to either vaccine hesitancy or some of those structural barriers that you mentioned too.
So for that analysis, we did not look at other demographics, but we did do another kind of sub-analysis in conjunction with DPHHS. And this was based off, well, this is all the same study, but this early childhood study. But we did recently analyze data on early childhood vaccine coverage and patterns in American Indian children in Montana and non-Hispanic white children in Montana. And we did this work also in conjunction with All Nations Health Center, which is here in Missoula, Montana, the Urban Indian Health Center here, who we have a great collaborative research relationship with. So in that analysis, and this is kind of our main focus on demographics, we found that American Indian children have lower vaccine coverage at age 2 years than non-Hispanic white children in Montana. And that is primarily due to patterns indicative of structural barriers, not parental hesitancy. And in fact, what we really see when we look at the data are kids that kind of start vaccine series late or fall behind at getting doses. And the way these vaccine series work is that they have to be timed in a certain way that if you start falling behind, it's hard to get caught up on time. And so that really helped pinpoints opportunities for intervention, which are really should be steered more toward making sure that these series are started on time at most of the series the multi-dose series we're talking about need to be started at age 2 months. So kind of steering public health initiatives in that direction.
So kind of in line with that, what do you see as some of the biggest opportunities perhaps to maybe address some of these structural barriers that you're talking about? Maybe at a community level or more broadly at a state or a regional level too?
Yeah, I think it has several layers. I mean, I think the biggest opportunities, like I talked about, are provider and clinic level strategies. So really like health systems strategies that can be implemented that we know that there's good evidence it can be very effective in increasing vaccination rates. And we have some health systems in the state that are like knocking it out of the park. But we know that a barrier there can be just resources. So opportunities really from a policy and like a state and that federal funding standpoint that can help steer resources toward clinics that can help kind of, put into place the resources that are needed to do some of these clinic level strategies like reminder recall, I think can be super valuable. And then at the same time, I've been really enthused. I present to different groups. I've presented to nurses and doctors, and I feel like we have a medical and public health workforce here that wants to put into place different strategies to help increase vaccination rates. So I think that is another kind of linkage, is just helping really those boots on the ground immunization providers learn a little bit of the science and what we know about what is effective and what works in having these vaccine conversations. And then of course, listening and learning, because we know what we know from research, but people, there are a lot of people, great nurses and doctors that are, that they probably can share some great strategies on what's working for them in terms of increasing vaccine confidence and increasing vaccine uptake.
Fantastic. So I don't see any additional questions coming in, but my last question for you is, what's next? What are the next things that you're exploring related to vaccination and youth?
Thanks for that question. So we recently got another NIH study to do a kind of in-depth qualitative study on vaccine confidence and hesitancy in rural and indigenous adults. And that's another project we're doing with All Nations Health Center. So we are just really interested in learning more and documenting from adults what helps them be more confident about vaccines and what is stopping them from being confident about vaccines. So that's a project that we just started. I'm also really interested in continuing to work with our state partners and other partners about taking some of our findings and translating them into new strategies and new practice. So in particular, with regard to like the HPV data that I shared, we are having discussions now about, are there initiatives that we can look at in terms of decreasing missed opportunities in public health departments, decreasing missed opportunities for HPV vaccination. So I also have a national study I'm working on looking at national trends in under-vaccination. I'm using some national CDC data. So I love to focus on Montana. I've really enjoyed working in this space, and Montana is such a collaborative atmosphere to be working in public health and in, but I do try to also still stay involved with some national work.
Great. And so we have one more question that's come in here regarding the patterns of HPV vaccination. Do you have areas in Montana where vaccine hesitancy is encouraged by primary care providers and or public health departments and may be influenced by the provider's personal beliefs?
I think that is certainly the case. And we certainly hear about that. And also, as part of this NIH study, we're about to launch a survey of primary care providers in Montana to try to gauge this. Well, we're gauging a few things, but I would say though, I think that is the exception and not the norm. The norm is that the vast majority of physicians and primary care providers support and endorse vaccination. I think the problem you run into in a state like Montana is that oftentimes you have very limited options. So if you are in an area where if there is a provider who isn't enthusiastically recommending vaccines, that could of course be a factor. And we should also acknowledge that it's not just enthusiasm for vaccines. If in a medically underserved area, there are so many different medical and public health priorities to think about and to acknowledge and to deal with your patients, that it just might be that immunizations are not, the top of the list. So I just want to, acknowledge that there are other barriers that can be occurring as well.
Potentially a lot of factors at play.
Exactly.
Fantastic. Well, thank you so much for taking the time to share with us today. I'm going to go ahead and stop the recording, but we really appreciate all that you've shared with us and look forward to hearing what comes next as well.
All right. Thanks, everybody. Bye.